ahead and get started. We have a great morning this morning. Before I turn things over to Dr. Burfield, who's going to introduce Dr. Farjah giving grand rounds, I just want to recap last month. Last month, we had the 26th Annual Helen and John Schilling Research Symposium. And just to remind all of you, so we took 3 weeks and spent 2 hours on each of the subsequent Wednesday mornings to have our visiting professor, Dr. Robin McLeod from Toronto, who was terrific and inspiring, and then our residents and fellows presenting their research. And this is always a highlight of the year for the department, to see the kind of depth and breadth of research that we have going on in the department. And I think we did well. We pivoted to a virtual format. Instead of having 8 hours of presentations over a whole day, which I don't think any of us could have tolerated on Zoom, we made the decision to split it up into 3 2-hour sessions, which I think went very well. Really want to thank Dr. Flum for all the work that he and the research team did pulling this together, but also Alison Fiddler and Savannah Tam and Michael Hillary for all their work in making a successful Schilling event. But this is the moment that you've all been waiting for, because we have prizes, we have awards, and we had 31 presentations, and so we have third place, second place, and first place in the research presentations, and these are cash awards. There's money involved here. So this was really tough for the group that was evaluating all of the presentations, but I'm really pleased to let you know who the awardees are for the 26th Annual Helen and John Schilling Research Symposium. So, Allison, let's go to the third place. Third place was a tie, 3-way tie. Dr. Alan Utria, urea cycle dysregulation and fibrolamellar carcinoma. Dr. Miriam Hantuli, acute cholecystitis during pregnancy, when and should you operate? And Dr. Dara Horn, HLA-A locus is associated with sepsis and septic shock after traumatic injury. So congratulations to Drs. Utria, Hantuli, and Horn. Let's go to second place. Also a tie. We have 2 second place winners. Dr. Irene Zhang, Americans' Perspective on Opioid Minimization After Surgery and the Impact of Surgeon Messaging. And Dr. Alex Lois, The Use and Safety of POEM and Other Definitive Management Strategies for Achalasia. So congratulations to Drs. Zhang and Lois. Great job, you guys. So drum roll for first place. Slide. First place, Dr. David Droulard, Assessing the Impact of Diverticulitis on Quality of Life Over Time. Dr. Droulard, great work. Even more impressive than your output on Peloton. Let's see, Ride to Climb, right? Yeah, I know who you are. So congratulations to all of the winners. These were great presentations. I actually wish we could give out more awards because I really think the whole group did such a great job. Thank you. Congratulations to the residents and fellows that won. And I'm going to turn things over to Dr. Burfield, who will introduce this morning's speaker.
Wonderful. Congratulations, everyone. Good morning. I have the pleasure of introducing Dr. Farhood Farjah, one of my partners. Dr. Farjah is an associate professor and thoracic surgeon at UW Montlake. He's the Endowed Chair in Lung Cancer Research, as well as the Associate Medical Director of SOURCE. As many of you know, Dr. Farjah did his general surgery training here at the UW, where he also completed his MPH before going on to Memorial Sloan Kettering for his thoracic surgery fellowship. And he returned to Seattle in 2012. Dr. Farjah's clinical focus is in thoracic oncology, and his research focus is in health services. And without further ado, I will turn it over to Dr. Farjah to talk to us about quality improvement in thoracic surgery.
Thanks, Dr. Burfield. Good morning, everyone, and congratulations to all the winners and everyone who participated in the Schilling conference. I'm going to share screen, and I would appreciate feedback. What are you looking at, Dr. Burfield?
Your title slide looks great.
Perfect. Well, thank you for the opportunity to present. Although the topics today, or the talk today, will focus on thoracic surgical oncology, many of the concepts are generalizable to other surgical practices. My only disclosure is that I'm the PI of a study evaluating outcomes of individuals with incidentally detected lung nodules, and I don't think it impacts this presentation. The reason why we attempt to define quality so that we can measure it in an unbiased fashion. And here's a widely known definition: the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Additionally, quality health services should be effective, safe, patient-centered, timely, equitable, and efficient. But there are limitations to this definition. For instance, it's unclear how we should classify quality. It's much easier to act upon a classification of high versus low quality, even though quality probably exists along a spectrum. Another limitation is that we don't know how to resolve differing perspectives. If individuals and populations have differing perspectives on quality and in ways that are at odds with each other, then we have no way of prioritizing one view over another. Yet another limitation has to do with the uncertainty over the best comparator. It's unclear whether the frame of reference for determining quality should be an alternative health service, care provided by another clinician, or the population average. And I don't think there are right or wrong answers. And therein lies the problem, because there's the potential for subjectivity. And subjectivity, whether it's perceived or real, is a threat to the legitimacy of any quality improvement effort. And yet it's precisely our subjective sense that the delivery of care is so bad sometimes that we're compelled to pursue quality improvement, even if we can't define it well. So I want to spend some time talking about measurement frameworks. And although there are several cardiothoracic surgeons and many other surgeons often use the Donabedian framework. It was published 55 years ago, and it has 3 elements: structure, process, and outcome. Outcomes refers to the end result of healthcare delivery on a patient or population. Patients experience multiple outcomes, we know this, and different outcomes represent different concepts such as safety, effectiveness, quality of life, and satisfaction. Outcomes-based quality initiatives rely on benchmark performance feedback to drive change. Structure refers to the environment in which healthcare is delivered. For instance, an operation might be done by a specialist or a generalist at a high or low volume hospital. Structure-based initiatives assume that a particular structure leads to better outcomes, and generally speaking, structures are not modifiable. Consequently, in order to improve outcomes, structure-based initiatives rely on centralizing care. Process refers to discrete things that we do for patients, such as operating on them, using certain surgical devices, prescribing drugs, or ordering diagnostic tests. Process-based initiatives assume that the process leads to better outcomes. Unlike structures, processes are modifiable in that there are varying degrees of adherence with the use of recommended processes. And process-based initiatives attempt to improve outcome by providing providers or clinicians benchmark performance feedback in terms of process compliance. So given that overview, I'm going to delve a little bit deeper into the advantages and disadvantages of these different quality metrics. The advantage of outcome measures is that they represent the bottom line, meaning it's the effect of healthcare on patients and populations. But in order to make fair comparisons, you have to account for case mix, because surgeons and hospitals will often claim that their patients are sicker. In fact, I've always felt that the lung cancer patients at the UW are sicker than the patients at Sloan Kettering, where I trained. So here's the average pulmonary function for two identically selected populations, one from Sloan Kettering and one from UW. And remember, lower predicted FEV1 and DLCO values are associated with higher risks of complications and worse survival. UW patients indeed have worse lung function than Sloan Kettering patients. So if you were to compare outcomes across these two hospitals, you'd have to adjust for differences in lung function. It'd be unfair to attribute worse outcomes to UW just because we take care of sicker patients. It'd also be unfair to view our outcomes as equivalent without acknowledging that we take care of sicker patients. So another challenge with outcome measurement is that you need to discriminate between signal and noise. In this case, signal means true differences in outcomes, and noise means random variation in outcomes. So let's say you compare operative mortality for lobectomy across two hospitals, and each hospital operates on one patient only. At hospital A, the patient dies. At hospital B, the patient lives. There's a huge difference in outcomes, but hopefully it's totally obvious that the reliability of these mortality estimates is low because there's simply too few patients. So stated differently, chance may explain the difference between these two hypothetical hospitals' outcomes. So let me tell you about this figure and make it a little bit more real. This figure helps us understand the median number of cases a hospital needs to perform over 3 years in order to detect a doubling in mortality rates. Now, these procedure-specific mortality rates are 20 years old, so just forget about them. They're outdated. But the relationship described by this curve is timeless. So the operative mortality rate for pulmonary resection on average is 1.2% for hospitals participating in the Society of Thoracic Surgeons General Thoracic database. And the median hospital volume for pulmonary resection in the US is 42 cases per year, or 120 cases over 3 years. So in order to identify a hospital that has a mortality rate of 2.4%, or twice the national average, that hospital would have to do 250 cases a year. So if a doubling in mortality is important, then most hospitals in the US don't do enough lung resections to discriminate between signal and noise. So one way to manage this problem statistically is to use a technique called reliability adjustment. And if you know from large samples that the average mortality rate is 1.2%, then the technique moves each hospital's mortality rates closer to that mean. Now, there are limits to that technique, and I doubt it would work in this hypothetical example of n equals 1 for each of these hospitals. Another disadvantage of outcome measures is a temptation to use surrogates. Many years ago, the Society of Thoracic Surgeons decided to measure prolonged length of stay greater than 14 days as a surrogate for morbidity. And the reason for that choice was that mortality rates after lung resection were too low for reliable hospital comparisons. Prolonged length of stay greater than 14 days occurred in about 7% of patients on average. And you can see here that it would be possible to detect a doubling in this outcome with only 33 cases per year. And given that the median volume is 42, this surrogate is enticing. However, it's unclear why prolonged length of stay happens in only 7% of patients when 38% of lung resection patients have a complication. So we conducted a single institution study of about 2,600 patients undergoing lung resection over 10 years. And just like other hospitals across the nation, there was a large difference in rates of prolonged length of stay and complications. Almost everyone who had a prolonged length of stay had a complication. However, 79% of patients with a complication did not have a prolonged length of stay. So stated differently, the surrogate prolonged length of stay misses 4 out of 5 patients with a complication. Now, it's entirely possible these complications were minor. So to test this idea, we took all 733 patients who had a complication and compared those with and without prolonged length of stay in terms of the severity of their adverse events. And as you would expect, patients who had a prolonged length of stay were more likely to have severe events. But note that grade 2 or higher adverse events means that inpatient therapy is needed to treat that complication. So stated differently, the surrogate prolonged length of stay misses nearly 9 out of 10 patients with complications who require inpatient therapy. And this finding challenges the idea that complications missed by prolonged length of stay are clinically unimportant. So the Society of Thoracic Surgeons no longer uses prolonged length of stay as a primary performance measure. Instead, it uses a composite endpoint of major morbidity and mortality. Another challenge with outcome measures is that improving one might compromise another, and therefore it's advisable to look at multiple outcome measures. Several years ago, the UW led an effort to create a regional quality improvement initiative for thoracic surgery based on the infrastructure and network of SCOPE, which you all know. One of our projects was to reduce the length of stay statewide. So we looked at reliability and risk-adjusted outcomes of hospitals, of 24 hospitals within Washington that perform lung resection. And Hospital D had the lowest mean length of stay. This hospital was poised to lead us in reducing length of stay across the state. However, Hospital D also had the second highest readmission rate in the state. The surgeon leader at that hospital was not tracking readmissions into other facilities, and as a consequence was unaware that his success reducing length of stay came at the consequence of excess readmissions. So another disadvantage of outcome measures is that they are resource intensive. High quality clinical data is expensive to collect because we still rely on humans to gather that information. The data collection includes information on both covariates for risk adjustment and outcomes of interest. Additionally, you need a biostatistician to create risk adjustment models for each outcome, every procedure, and they need to do reliability adjustment. And finally, you have to give the clinicians a report that's user-friendly and actionable. Finally, another disadvantage of outcome is that performance feedback alone may not drive change. This study evaluated the outcomes of hospitals over time, stratified by whether or not they participated in ACS NSQIP. The patient population is general and vascular surgery patients. This ACS NSQIP program provides hospitals risk-adjusted outcomes data. And you can see here, hospitals participating in ACS NSQIP had better outcomes than non-participating hospitals across all time points. And the outcomes of every hospital, regardless of group, improved over time. The investigators used state-of-the-art techniques to determine whether the rate of change over time was different between these two groups, and it was not. So two different research groups reached this conclusion independently using entirely different data sources. And the most likely explanation for these null findings is that hospitals that participated in ACS NSQIP had no intent to use their performance data to drive change, or hospitals had every intent to drive change with the use of performance data, but they couldn't figure out how to make that information actionable. So unlike outcomes, processes of care are easy to measure. You need a denominator that represents the number of patients who are eligible for that process, and you need a numerator, which is the number of patients who actually got that process. You don't need risk adjustment, and you only need reliability adjustment if your denominator is small. One of the disadvantages, and this is a really important one, is that there is clinical and scientific uncertainty over a causal relationship between process and outcome. And I'm going to use the example of nodal staging for lung cancer to highlight this issue. So many lung cancer patients undergo a CT and PET for staging, and those without metastases, the focus turns to the extent of lymph node involvement, if any, through a process called nodal staging. Nodal staging is essential for treatment selection. So for instance, patients without nodal disease should undergo local therapy, preferably surgery, and if medically inoperable, then radiation. Those with minimally extensive disease should undergo a combination of chemotherapy plus surgery or radiation. And those with extensive nodal disease should undergo definitive chemoradiation followed by immunotherapy. Now, understage patients may be denied chemotherapy. Trials show that chemotherapy improves survival over surgery alone for patients with any nodal disease, and therefore omission of chemotherapy negatively impacts survival. Additionally, understage patients may undergo unnecessary surgery. Resection offers no oncologic benefit for patients with extensive nodal disease, but it does expose the patient to the risks and the morbidity of that operation, which could adversely affect survival. Overstaged patients may receive unnecessary chemotherapy. Trial data shows that chemotherapy is associated with worse survival among patients without nodal disease and small tumors. Additionally, overstage patients without true nodal disease may be denied standard of care resection, which would in turn negatively affect long-term outcomes. So the point here is that inaccurate staging leads to inappropriate treatment, which results in suboptimal patient outcomes. So here's how nodal staging works. Because CT and PET have a false positive rate of 38% and a false negative rate of 10%, practice guidelines recommend invasive staging for patients at high risk of nodal disease. And invasive staging consists of mediastinoscopy, endobronchial ultrasound guided biopsies. For patients without high risk and are determined to be low risk, they should proceed to local therapy. Imaging findings that confer a high risk of nodal disease include lymphadenopathy, FDG uptake in lymph nodes, centrally located tumors, and tumors greater than 3 centimeters. So here's the perceived quality issue. If you take a population of lung cancer patients staged with CT and PET and without evidence of metastases, 75% of them will have a radiographic finding that confers a high risk of nodal disease. So the expected rate of invasive staging is 75%. But nationally, actual rates of invasive staging are 10 to 35%, depending on the data source and the population studied. It's this chasm between expected and observed rates of invasive staging that it's led some to believe that the quality of thoracic oncologic care in the US is poor. And I believed it too, right up until the point that I started my clinical training at another cancer center where practice patterns were markedly different. So again, here are data on 2 identically selected lung cancer patient populations with a 9-fold difference in the use of invasive staging across these 2 major medical centers. How could that be? Well, like all narratives in medicine, the devil's in the details. Rates of clinically significant understaging and overstaging are unknown. False negatives and false positives for imaging do not directly equate to under and overstaging because of the nuances of stage classification and the nuances of how we treat different extent of nodal disease. Additionally, the literature on imaging performance is limited because they largely consist of single institution retrospective studies with highly selected patient populations, which can actually make the information totally uninterpretable. Finally, clinicians put different weights on the severity of some of these inappropriate treatments, which impacts their perception of the significance of these intermediate endpoints. So now that we saw 2 different practice patterns at cancer centers, we also were curious if there was hospital level variability in invasive staging in the community setting. So we again leveraged data from the Regional Quality Improvement Initiative that we tried to pull off in Washington State. And only one of these hospitals is an academic center. The other 4 are community hospitals. And what this analysis tells us is that indeed there's hospital level variability and invasive staging that exists in the community in addition to across cancer centers. And this study was consistent with another study we did years ago. Among Medicare beneficiaries with lung cancer, there was no difference in invasive staging between specialists and generalists. And so if you look at specialists, here's variability in invasive staging across 29,000 patients cared for at 256 hospitals participating in the Society of Thoracic Surgeons clinical registry. The surgeons at these hospitals are predominantly board certified. And the y-axis, instead of showing you raw rates of nodal staging, it's rates relative to the mean. And on this scale, there's 25-fold variation in invasive staging across centers. This center-level variability in invasive staging described in these studies was not explained by case mix, chance, access to care, academic versus community, specialty versus generalist care. And variation that's not explained by these factors represents either a quality gap, an evidence gap, or both. So we were awarded a small grant from the Chest Foundation to try to dig a little bit deeper with a prospective study. And to do so, we created a scorecard to assess the performance of guideline recommended nodal staging strategies. Specifically, we asked how often a strategy recommended invasive staging in a patient who truly had nodal disease, and how often the strategy recommended invasive staging in patients without nodal disease. And the gold standard for assessing nodal disease was the result of a mediastinoscopy and a bronchial ultrasound, or intraoperative lymph node evaluation at the time of lung resection. A guideline concordant staging strategy recommended nodal staging for 100% of patients with true nodal disease, but it recommended invasive staging for 65% of patients who did not have nodal disease. So stated differently, guidelines do a superb job selecting patients with nodal disease, but it's inefficient because it results in many people without nodal disease to undergo an unnecessary invasive procedure. Now, the risks of these procedures, mediastinoscopy and the bronchial ultrasound, are really, really small, but the complications are severe, including pneumothorax, hemothorax, either of which require intervention, great vessel or airway injury, or procedure-related death. Additionally, these procedures cost payers thousands of dollars. Now, what we don't know is how guideline discordant staging performs, because in this pilot study, all the patients got guideline concordant care. And if there are real differences in performances, then we also don't know if those performances translate into survival differences. So in March of this year, we submitted a proposal to the NCI to test whether survival rates were different between lung cancer patients who received guideline concordant versus guideline discordant nodal staging. And if funded, this study will evaluate the care of patients at Kaiser Permanente in Washington, Kaiser Permanente in Northern California, and Marshfield Clinic in Wisconsin. These integrated health systems are part of the Cancer Research Network, and their data platforms allow us to access both structured and unstructured data within their robust electronic health records so that we can conduct this comparative effectiveness study. A second aim of this study was to see if an alternative strategy could outperform current guidelines. So we came up with an idea for an alternative staging strategy that mimics guidelines with regards to its structure and its clinical decision-making framework, but we used a different risk stratification approach. Specifically, we created a risk model to predict the probability of lymph node disease. We used the same radiographic factors as guidelines. We also added the standardized uptake value of the primary tumor on PET as an additional risk factor. And within a margin of error, the risk-based strategy is expected to perform as well as a guideline recommended strategy with regards to recommending invasive staging in patients with true nodal disease. However, the risk-based strategy is expected to direct fewer patients to an unnecessary invasive procedure, meaning those people that don't have nodal disease. So the second aim of our grant proposal is the second hypothesis that a risk-based nodal staging strategy is equivalent to a guideline concordant nodal staging strategy in terms of survival, but it's superior in terms of fewer procedure-related adverse events and lower payer expenditure. So the point I'm making with all of this is that you can have an incredibly well-reasoned clinical rationale for a process of care, and despite that, there can be considerable clinical and scientific uncertainty about the impact of a process on outcomes. So another disadvantage of process measures is they were not intended to measure overutilization. We compared repeat utilization of diagnostic tests among commercially insured lung cancer patients who received guideline concordant and guideline discordant pre-op testing. And guideline concordant care referred to not only getting a recommended test, but also getting it within a recommended time frame. So for instance, for pulmonary function tests, it's within 180 days of resection. And for CT or CAT scan, it's within 90 days of resection. And what we found that repeat testing occurred more often in the guideline concordant group. Now, repeat testing is not necessarily a bad thing. It could be a marker of appropriate care if the quality of the initial test was poor or if the testing was outdated. However, you'd expect poor quality and untimely tests to occur more often in patients who initially got guideline discordant care, but we saw the exact opposite result. So repeat tests are not without their consequences, include radiation exposure, delays in treatment, and costs. So the point here is compliance is not synonymous with appropriate utilization. So like process measures, structures of care are easy to measure. For instance, it's relatively easy to figure out if a hospital's annual case volume, or whatever a hospital's case volume is, or if a surgeon is board certified. Unlike or excuse me, rather like processes of care, there's the same issue of uncertainty over the relationship between the structure and the outcome, meaning does board certification lead to better outcomes? Does higher volume lead to better outcomes? Or is it merely a correlation? So, for instance, there's this well-described volume outcome relationship, and it's prompted some major academic centers to take the volume pledge. So the idea here is to centralize patient care within large health systems to only those hospitals and only those surgeons who meet these minimum procedure-specific volume thresholds. However, the relationship between these thresholds and outcomes have not been rigorously tested. So using the Society of Thoracic Surgeons clinical registry, we compared outcomes between lung cancer patients cared for by surgeons and hospitals who did meet the minimum volume thresholds and those who did not. There were over 32,000 patients in this study. They were cared for by 465 surgeons and at 209 hospitals. And there were no differences in rates of complications, operative mortality, failure to rescue, or the Society of Thoracic Surgeons composite measure of major morbidity and mortality. So to better understand this null result, we evaluated the relationship between volume and outcome along a continuous scale and without making assumptions about linearity. So the only outcome that hospital volume had a relationship with was complication rates. Not only did we find evidence of a non-linear relationship, but we found that volumes below the national median of 42 cases per year were associated with lower complication rates. So let me say this again, lower volumes, better outcomes. So one plausible explanation for this unexpected finding is that less busy centers have more bandwidth to prevent complications. Now, surgeon volumes had no significant relationship with complications, operative mortality, or failure to rescue, but there was an inverse linear relationship between surgeon volume and the STS composite for major morbidity and mortality. However, outcomes were better at a threshold of 60 cases per year, 3 times larger than the median number of cases a surgeon performed with regards to lung resection. And in this cohort, only 8% of patients were cared for by surgeons who performed 60 or more cases per year. So at least for lung cancer, these volume thresholds were not associated with better outcomes because of false assumptions about the directionality and linearity of associations between hospital volume and outcome, and because of incorrectly selected thresholds for surgeon volume. Another disadvantage of structural measures is that they may exclude top performers from providing patients care because associations between structure and outcomes are based on averages rather than individual performance. This figure shows the STS composite score for hospitals performing esophagectomy, and the hospitals are ordered by their volumes. In this case, a higher composite score actually represents a better outcome. The solid black arrows at the top identify statistical outliers in terms of good performance, and the dashed black arrows at the bottom identify statistical outliers with regards to poor performance. And you can see 3 out of 5 top performers fell below the minimum hospital volume threshold for esophagectomy. So the point here is that centralization can deny patients access to top performers. Another disadvantage of structural measures is that centralization may exacerbate health inequity. This study showed that a disproportionate number of Black, Asian, Hispanic, uninsured, and Medicaid patients with lung cancer received care at lower volume hospitals in California. Centralization assumes that these segments of the population can access high volume centers and actually are willing and want to go to high volume centers. And in this way, if this assumption is wrong, centralization may restrict access to care and marginalize populations. And to be specific, these marginalized populations can transition, in theory, from having care at low volume hospitals to not receiving any care at all. So the take home point, or at least one of them, is structure, process, and outcome. It has many pitfalls. And so I want to spend the last 10 minutes telling you about a new quality improvement initiative. In 2017, the American College of Surgeons and Society of Thoracic Surgeons decided to co-sponsor a verification program for general thoracic surgery. This new quality program is modeled off the college's experience with trauma and bariatric surgery verifications programs. It's actually part of a broader vision of expanding verification to pediatric, vascular, high-risk GI surgery, and possibly other surgical areas. Verification is disease-based rather than procedure-based, and it takes on the perspective of a patient going through 5 phases of care, including the pre-op clinic setting, immediate pre-op, intra-op, post-op, and post-discharge. And as of yesterday, the UW was the second program in the nation to undergo a site review. And before I get into the development and implementation of verification, I want to try to conceptualize it a bit for you. So verification is fundamentally a structure of care that specifies the minimum number of resources needed to achieve optimal patient outcomes. These resources include equipment, facilities, expertise, but they also refer to the governance, organization, and financing of a thoracic surgical program. Verification requires thoracic surgery programs to specify key processes of care, and it encourages programs to adhere to national practice guidelines. However, programs ultimately, or hospitals ultimately get to choose what processes they want to adopt because they believe they do or do not impact patient outcomes. And verification requires thoracic surgery programs to monitor process compliance and to react accordingly to non-compliance by either modifying their processes or by changing their structures through acquisition of additional resources. Finally, verification requires thoracic surgery programs to participate in regional or national clinical registries to monitor benchmark risk-adjusted outcomes and to demonstrate a response to performance feedback by, again, changing structures through acquisition of additional resources or by modifying processes. A more formal and official description of the fundamentals of verification are detailed in this book by Drs. Hoyt and Co. of the American College of Surgeons. So I want to give you a little bit less of a theoretical and more of a pragmatic view of what verification looks like. So core principles underlying verification include setting standards, building infrastructure, collecting robust data, and verifying through a third party. Standard setting and site visits are a function of the college and the Society of Thoracic Surgeons. Infrastructure building and data collection are the responsibility of the hospital. The verification cycle is every 3 years. There are 8 standards for thoracic surgery, including hospital administrative commitment, program scope and governance, hospital and equipment, resources, personnel, and services, patient care expectations and protocols, data surveillance systems, quality improvement, and participation in research. And there's a 56-page document that provides a more granular description of these standards. And just to give you a sense of one of them, the standard on care pathway specifies that at a minimum, a thoracic surgery program has to have a non-narcotic analgesic plan, a lobectomy protocol, esophagectomy pathway, and a postoperative pain management pathway. So in preparation for a site visit, we were asked to provide documentation that supports adherence with the standards. For example, we provided copies of our pathways so the site reviewers could see what they're made of. In addition, we were asked to provide greater specificity on the stakeholders involved in pathway development, how team members were involved or how team members access pathways, how guidelines are integrated into pathways and barriers to pathway development and implementation. Finally, we were asked to submit a chart inventory, which included the medical records of patients who experienced predefined adverse events within the last year. In addition, the site visitors wanted examples from airway, pulmonary, pleural, esophageal, diaphragm, mediastinal, chest wall, and endoscopic procedures. We submitted 71 charts and 23 were selected for review. The actual visit was virtual because of the pandemic, split over 2 half days, and in lieu of walking around the hospital for a physical inspection of the facility, we were asked to create a video detailing the patient's journey through the 5 phases of care. And then there was a 3-hour session where the site visitors got to review those 23 charts with us in depth and ask us questions about the processes and structures that led to those adverse events. And as a result of those adverse events, the processes and structures we were going to modify or acquire in order to avoid those events in the future. The majority of the agenda actually consisted of interview with key stakeholders, including surgeons, advanced practice providers, anesthesiologists, intensivists, nurses, allied specialists like oncologists and pulmonologists, as well as the C-suite leadership. The last meeting on the agenda was a preliminary summation of the site visitors' impression of our application or our program. And so next I want to tell you a little bit about the development of the standards. So through his executive roles in both the American College of Surgeons and the Society of Thoracic Surgeons, Dr. Wood invited me and Dr. Lisa Brown at UC Davis to join him and Dr. Allen to create a team of 4 thoracic surgeons to draft the standards under the mentorship of Dr. Hoyt, who's the executive director of the American College of Surgeons. The standards were then vetted by 3 surgeons representing 3 different thoracic surgical professional societies. Then the college invited representatives from non-thoracic surgical professional societies to vet these standards, including folks from anesthesia radiology, interventional radiology, pathology, pulmonary, and gastroenterology. Finally, the college invited 4 surgeons from non-academic community programs embedded in either integrated or non-integrated health system to also vet the standards. So the phase we're on now is piloting the studies. UC Davis, we're first, we are second. So it's too soon to know the advantages and disadvantages of verification, but there's some limitations we can acknowledge today. The benefits of participation remain theoretical. Evidence that verification leads to better patient outcomes will be a compelling reason for hospitals to participate, but that evidence doesn't exist yet. Dr. Brown and I have had preliminary conversations about how we can use mixed methods research to evaluate the impact of verification on patient outcomes and stakeholders as it rolls out across the country. Participation may give surgeons a lever to acquire more resources for patient care. Site reviewers identified areas of improvement at Davis and UW, but it's too early to tell whether we will acquire more resources as a result of this feedback. Participation may also give hospitals and health systems a competitive edge in acquiring and negotiating payer contracts. The college has approached a major payer, and a major payer has approached the college about verification, but those discussions are ongoing. But there's also potential unintended consequences of verification, including restricting access to care. Now, unlike other structure-based quality initiatives that intend to centralize care, verification is intended to be the tide that raises all boats. However, if a health system decide to restrict care to only hospitals that are verified, or if payers decide to only contract with hospitals and health systems that are verified, then again, there's this potential of restricting access to care. So to be clear, at UW Medicine, we have no intention of restricting care to Montlake. Thoracic surgery will continue at other hospitals in our program, even though they're not verified. Restricting access may also exacerbate health inequity, again, for the reasons related to restricting access to care. And at least at Davis, the reviewers were asking that hospital and that health system what they were going to do to ensure the care of marginalized populations within their encatchment area. So to wrap up, I just want to return to the title of this talk. When I started my postdoc, I was incredibly optimistic that quality improvement could save lives. However, most of our research demonstrated the pitfalls of quality measurement, which naturally led to an enormous amount of skepticism. But the knowledge generated from this research in some ways informed the implementation of the thoracic surgery verification program. And to be invited to sit at the table and ask the college and the Society of Thoracic Surgeons really hard questions about how this program was going to be different is truly an incredible opportunity. And it's because of the colleges and the Society of Thoracic Surgeons' openness to that critical perspective that I'm once again optimistic that quality improvement can save lives. Now, I expect we'll gain a better understanding of advantages and disadvantages of verification, and I am now prepared to grow skeptical about verification eventually. And I know it's going to happen, but I'm okay with it. I think now I can accept this cycle has to keep happening over and over again in order for us to get better. So I'm so grateful for the many stakeholders who make our thoracic surgery program so successful. I want to thank Dr. Wood for inviting me to a seat at the table nationally to spearhead this verification process for thoracic surgery. I want to thank Dr. Flum for being my mentor in quality improvement research, and I am grateful for Dr. Mulligan's leadership in supporting our clinical and academic endeavors. And I would be remiss if I did not acknowledge that much of the research you've seen today represents the hard work of residents who graduated from our general surgery program. Dr. Lucas Thornblade is a surgical oncology fellow at the City of Hope, and he's in active negotiations for a faculty position at a major academic center. Dr. Frances Verdial is a breast surgical oncology fellow at Memorial Sloan Kettering, and she told me I can share this with you. She just accepted a faculty position at the Massachusetts General Hospital. Dr. Megan Flanagan, who's also trained at Memorial Sloan Kettering, as many of you know, is a busy clinical breast surgeon at the Seattle Cancer Care Alliance, and she's the recipient of 4 research grants. Thank you for your time. I'm happy to answer any questions.
Well, I'm going to start with a comment before we get into questions, because I'm, listening to Dr. Farjah present this, I have been reflecting on a couple of points. One is this is a master class in a grand rounds, and one of the things that I want to point out is we started off this presentation with awards for the Schilling Research Symposium. So Dr. Farjah was the recipient of some of those awards 12 and 13 years ago. So those of you residents who presented, this is you in just a few years. And I want to reflect on the mentorship of Dr. Flum and recognize his impact on the work that he's done with Dr. Farjah, and that Dr. Farjah now is incredibly successful as a surgeon scientist in health services research. And I think what I'm proudest about is as we went through his talk, I was noticing how influential Dr. Farjah's research is, and putting it together. And about 2/3 of the papers that he cited were papers from here, and that included our residents and fellows, as he just highlighted. So kind of all of that is exactly what we want to see in a rich academic surgical program. Mentorship from a senior person, a junior person on their way to becoming a senior person, mentoring a new tier of residents and fellows, productivity that represents that output, and changes in care, and the development of this verification program that Dr. Farjah is a key individual in. So I just wanted to reflect on that before we move into questions. Really terrific, Farhood. Thank you for a great presentation.
Thank you. Thanks for the kind words. And thanks to the department.
Excellent. Well, so many comments and questions that come in. So one of which that's from Dr. Flum was, can you comment on the notion of safety in QI culture? Is safety in QI culture a structure or process measure, or both? And is it possible that these programs, accreditation and outcome measurement, are really just building up safety in QI culture across the entire field, and that's how they may impact outcome, even at sites that don't explicitly participate?
Yeah, the short answer to your second question is yes, I think that's what is happening. Your first question was, is safety in QI culture a process or structure? And actually, in one of the original slides I had for this presentation, I had arrows going back and forth between structure and process to reflect that notion that when we study quality improvement and we're trying to assign causality, like what's the thing that drives outcomes, oftentimes we don't know, and we don't know if it's the processes that define the structure or the environment in which care is delivered, or is it that environment that determines what the processes are. So that's a research setting. With verification, the point I was trying to make is it's very deliberate in saying everything starts with structure, and that leads to those processes. whether it's guideline adherent or not. And that structure demands that you're monitoring process compliance and you're monitoring outcomes. And you're not just monitoring them, but you have to do something about the information you're getting. And that's a way in which verification is a little bit more deliberate about the directionality between structure and process and structure and outcome, et cetera. That was that crazy figure I was trying to show you. And I guess the other, to your second question, I think it is a culture. I mean, so I did the site visit for Davis, and I'm not going to tell you details about that, but it now being on both ends of it, it's just fascinating. And as a surgeon, it's a little bit stressful for another surgeon to look at the chart of your patient. I mean, you feel so vulnerable, but it's healthy. And if you then say, like, let's forget about the complication, but let's say you follow guidelines for invasive staging. Well, when they look at that chart, they can be like, okay, well, you said you do, but there are indications for invasive staging, and you didn't do that. So Farhood, why didn't you do that? And so whether or not the invasive staging leads to better outcomes, I tried to make the point, I'm not sure, but it's this idea that if you say you're doing something, you're actually doing it. I think that speaks to the safety and the QI culture that you're referring to, Dave.
And then one of the comments that came in from Dr. Bulger was that, the verification process in trauma surgery has led to a lot of advances across the field. And now that you've been through this process and you've been in the field for so long and been a leader in it, what do you think the advances for thoracic surgery are that we'll see coming out of this?
I think it's a good question. First of all, I'd say we're really early into it, is my sense, and we're still learning. And I guess I'd want to hear what those advances are, because I'm not sure if the question is referring to like a different clinical pathway, or if it's advances in terms of research. There's Dr. Bulger. Maybe she can elaborate on the question.
No, I just say, Farhood, first of all, congratulations on this incredible work. And the trauma community started this process in 1976. And has been working to refine it ever since. And, I think what we've seen is the ability to build that culture that Dr. Flum is talking about, of sort of continuous quality improvement, not only in the surgical community, but in the nursing community that really supports and runs trauma programs around the country, and a close partnership with the Society of Trauma Nurses. So I think, if you think about sort of the broader implications of these programs, it engages the entire hospital, the administration of the hospital, the surgical community, and all the support staff in sort of a quality improvement mindset. And it does leverage more resources, at least it has in trauma. If a site visitor comes and says, you need to have this to maintain your trauma designation, the hospital usually finds a way to provide it, because the trauma designation is critically important to decide whether patients are going to be brought to your hospital or not by EMS. So I think, as we move forward, we have to look at what are the incentives to get programs to step up and be verified. And like you say, ties with payers and things like that also are another strategy towards that. I guess my question would be to think about, where do you think the biggest bang for the buck is? Like, is it in the standardization of protocols? Is it in structure of the quality improvement program around thoracic surgery? And what do you think the short-term gains are that you would anticipate from this process?
Yeah, I think, whenever I think of gains, I think about it in terms of what perspective are we talking about? The patient, the clinicians, the health system, et cetera. So from a patient, so the biggest bang for the buck, I think, is QI initiatives and value optimization initiatives, both of those. And they're a win-win for all stakeholders. So for patients, I think it's better outcomes. For hospitals, it's either cost savings or revenue generation. And for payers, I think it's better care for their population. So we actually provided examples of our QI initiatives. So we had a lab stewardship initiative, which saved $300,000 over the course of a year. Mm-hmm. And since reimbursements are DRG based, the payers are paying the same money, but the hospitals are saving $300,000. Another one is So that's cost savings. Dr. Wood is working on a OR efficiency at Montlake. That's another example of cost savings. Dr. Mulligan and Dr. Chang were part of a lung transplant pathway, which reduced length of stay, more capacity. That's cost savings, and it could be revenue generating by opening capacity. And then lung cancer screening is another one that we participated in, where it's a poorly implemented intervention that has level 1 evidence, and it's revenue generating. So everyone wins, but you need, like you said, you need to have buy-in from all the stakeholders. You need to have it financed. You need to have people with time to lead these initiatives, because they don't happen on accident or by chance, and they're not going to happen on nights and weekends. I think they might have in the past, but they're not anymore.
Terrific work and great presentation.
Thank you.
And then switching gears a little bit, one of the kind of comments that came in was that from Dr. Wright was that in the world of bariatric surgery, there's kind of mounting evidence of the use of video review of surgeons and technical skills. And do you anticipate that thoracic surgery would ever include that in the verification process or our processes?
I think it's entirely possible that it could be. It's been discussed, with the robotic platforms. As it turns out, it really lends itself to a lot of videotaping easily. And there are actually faculty in pediatric urology who I think are involved in a private company where they for robotic surgery across many specialties, where they have these individuals review videos, and maybe people on the call know about this program better than I do, but I've been approached to be a part of that. I ended up declining because we don't do a lot of robotic surgery yet, although we're about to launch in that direction. But to your point, and anything MIS, there's an opportunity for videoing. I think it's just a matter of the cohort of thoracic surgeons to identify value in that, and buy-in that there are objective measures of technique, and of course for surgeons to be open to it. That's another barrier to this, but I think it's a great idea, and it's gaining traction in multiple different surgical subspecialties.
I know that there have been talk, or at least in the training and mentorship of junior faculty, with the use of kind of video mentoring project for kind of case discussion and building of technical skills. So it's probably in the future. Great. Well, that was fantastic, and it is 7:29. So I think that great presentation. It was I took part minimally in the verification process, and it was a ton of work. So true congratulations and a big thanks to you, Farhood, for spearheading that.
Thank you. Bye, everyone. Have a good day.